Thanks very much, Francois, and thank you for asking me to give this talk, and thank all of you for coming at lunchtime. Those of you who came to a talk I gave previously last year, I hope you won't be disappointed if you think it's a follow-on, because last year I spoke about malaria immunology, and today I'm going to give a much broader talk, although immunology does, it turns out, have quite an important point to make about this. I'm really going to talk about what's happening with malaria since the turn of the century. And when you look at the media now, there's often pretty optimistic things about malaria, about elimination, the drive to elimination, and so on and so forth. But there are also some reasons for real caution and concern. Now, I'm going to try and give a balanced view of where I think we are right now. First, just a reminder to everyone that, of course, malaria is a global problem. It's one of the classical, if you like, tropical diseases. It occurs right through the tropics and, in fact, through temperate zones as well. But this kind of picture, although it's useful for an advocacy point of view, saying everybody should be really concerned about it because it affects everybody, doesn't really give a true picture of the problem as it is. If you look at where the parasites are, and that's expressed in this map, where the darker it is, the higher the parasite rates. And that means the more parasites people are just walking around with all the time. Then you can see that when it comes to where parasites are, they're really very strongly focused in Africa, although, of course, as I've said, malaria is a global problem. But even this kind of map doesn't give a true picture of the problem because it's focused on where the parasites are. But if you take into account where the people are, you get a much different picture. So if you say, well, who's really has malaria as a problem, then you can see that, yes, Africa for sure, but also particularly South Asia. And that's obviously because there are a very large number of people there. Nonetheless, it remains true that about 90% of the global mortality due to malaria is in Africa. And for that reason, although I've entitled the talk The Global Picture, I'm going to focus quite a lot on Africa because of its dominance in terms of global mortality. But that doesn't mean that Africa is the only thing we should be concerned with, and that will become clear as I move on. Why is it focused on children in Africa? People often ask this so why do we always talk about malaria being a problem in children in Africa, but in everybody elsewhere? And this is because the more parasites you've got, the more chances that a population develops immunity to malaria. And this schematic really just illustrates that. So this is the percentage of the maximum of whatever you're looking at in the population. And this is the age of a population. And this would be very typical of an African endemic population, where severe life-threatening malaria is really focused in younger children. In an area of stable malaria transmission, it's very unusual to die of malaria after the age of 5. You continue to have this so-called mild malaria until you're very much older. And you continue to be prone to be parasitized throughout life. At any one time, a proportion are parasitized, but in fact, everybody's probably parasitized most of the time, just at very low levels. But the immunity, such as it is, and it's pretty important because it stops people dying beyond the age of 5, is purchased at the cost of a very high childhood mortality due to malaria. And this is going to become important later on when we think about what might happen if we're successful in controlling malaria. At the turn of the century, malaria was quite appropriately described as a disaster. And in fact, a group of us wrote an article in The Lancet with that title, essentially, because nobody knew how many deaths there were, but it was almost certainly in the region of between 1 and 3 million a year, and it was probably towards the higher rather than the lower end of that. There was a complete lack, it seemed, of both national and international will to get to grips with malaria, and it was a major impediment to economic growth. And you can see that, in fact, what had happened in malaria in Africa as a continent was really quite worrying. Prior to the 1960s, of course, most African nations became independent in the 1960s. So in colonial times, this was the sort of estimated malaria-specific mortality for Africa as a whole. It doesn't matter what the actual units are. Interestingly, as nations became independent, they weren't doing a bad job at all in getting on top of malaria, at least in some countries. And there's a very wide spread, but malaria mortality was certainly falling until the 1990s, when it rose back up to at least the level of, and probably greater than, the sort of totally uncontrolled level of colonial days. So a really disastrous sort of shift back, loss of all control. And the reason for that was the widespread emergence of drug resistance, particularly chloroquine resistance. And this is a very important lesson that will also be reflected as I come towards the end of the talk. It was chloroquine resistance. Chloroquine is a fantastic, cheap, effective drug. It was chloroquine resistance which drove the mortality, probably doubled it, may have trebled it throughout Africa. In the end, there was a response to this. A whole range of international initiatives were put forward. I've listed a few of them here. Rollback Malaria, a sort of, if you like, a cabinet-level initiative of WHO, was started in 1998. Medicines for Malaria Venture. There was the Abuja Declaration. This was a declaration by all the heads of states of Africa that they would get to grips with malaria with some specific targets. And then the Global Fund for HIV, TB and malaria initiated in 2001. And even as this began to happen, I think it's true to say that many people, particularly on the sort of more academic and research side of the field, were sceptical, and probably reasonably sceptical, because it's very common to come up with these international declarations and then everybody sort of says, well, that's good, then something's being done, and then nothing happens. But I think this was a really good example where international advocacy and pressure, albeit late in the day, really had an incredible effect. Because if you look at what happened to expenditure for malaria control globally from 2004 to last year, it has risen from practically, so these are in millions, so here we're talking about $2.5 billion. It's risen from practically nothing or risen sort of strikingly, although what's worrying is that this is a bit flat here. It's just an extraordinary increase in international funding. So it isn't always true that advocacy and pressure is pointless. Clearly, there's a massive increase in global funding for malaria control. That's only of any use if you spend it on useful things. And the money was spent on all sorts of things, but two in particular accounted for a large proportion of it. One is effective drugs. Artemesinin combination therapies, ACTs, are now worldwide accepted as the standard treatment for malaria. A combination of a short-acting and other drugs. This shows the delivery of ACTs. Don't worry about what the colours are, they're just different brands, as it were. The key point is, as with funding, the actual global delivery of ACT doses has sort of climbed and climbed and climbed. It's sort of now at the level of about 400 million doses a year. This is clearly good news because these are very effective drugs, but it's still the case that more than 50% of all children in Africa suffering malaria do not receive prompt effective treatment with ACT. So you could say this is brilliant, and it is brilliant, or you could say, well, it's really quite worrying that despite the availability of totally effective drugs, most people who need it aren't getting them. The other big expenditure item for this massive funding is on impregnated bed nets. And again, there's a similar story. Beginning from an extraordinarily low base in 2000, practically nobody in Africa, except for in a couple of countries, really no substantial proportion of the population was covered with impregnated bed nets. And yet we knew that impregnated bed nets were a really very effective way of controlling malaria and reducing all-cause mortality. Perhaps one of the most effective single public health interventions ever. And yet it just wasn't being used. And that was because, largely, it was complex reasons, but funding was a major driver. And you can see that similarly, as with drugs, there's been a really massive increase. These are just different ways of expressing it, whether it's people under a net or sort of have a net and not under it. But the key point here is that around about 50% of everybody in Africa who should be under a net is now under a net. Brilliant achievement, but 50% aren't. And yet we know that nets are not totally, but they're extremely effective in reducing malaria and reducing childhood mortality. So again, you've got this balance of fantastic achievement. I think most people would be said wouldn't be possible to get this kind of level of rise, but still nowhere near where we need to be. You would hope that the expenditure of very large amounts of money on effective interventions would have an effect on malaria. So shown here from the World Malaria Report, in fact this is derived from the MAP project, is, so just need to explain what the colours are. As with all these maps, dark is bad, as it were. This is parasite rates in the population, and this is done by a kind of rather complex way of extrapolating from survey data right across Africa to give a smooth sort of version. This really, if you sort of screw your eyes up a little bit, this is really sort of saying where are there lots of parasites? And that was the picture in 2000, and this is the picture in 2013. So you can see there's been a very striking, apparent reduction in parasites in Africa. Looked at another way, and this is from work of my colleague and Abdeslam Noor and his group in Nairobi. Plotted here are the parasite rates in a population, as it were, for 2000 against 2010. And obviously, if you fall on the line, nothing's changed. If you fall below the line, things are getting better. And if you're above the line, it's getting worse. The size of the dots represent the proportional decrease. So the big dots mean that those countries have had a 40% reduction in their childhood parasite rates. And this little inset here is expanded here. And the point of this is to say, because what you might expect, you might say, yes, it's easy to deal with things when you've not got very many parasites to start with, down at this end of the curve, sort of just low levels of parasitization in the community. But in fact, that's not the case. The level of change has been pretty standard, however, whatever your starting position. So some countries have achieved really quite striking reductions in parasite rates, but some haven't, and a few have gone in the opposite direction. Nonetheless, overall, evidence of large-scale, widespread changes in the situation in Africa. Now, this is all about parasite rates. You would hope that that would translate to effects on cases and on deaths. This is a slightly complicated, but the key point about this is, so long as you're not this brick red colour, you're going in the right direction. So basically, blues or even the lighter browns are, so this is the proportion decrease. So blue means there's been a 75% decrease in malaria mortality rate in that country. And sort of you get to, you can sort of see a lot of Africa is in this sort of decrease by 50 to 74% or up to 49%. This is probably the most informative figure, that globally it's estimated that malaria mortality has fallen by 47%, and in Africa by 54% in just 13 years. Now, I need to issue a health warning here. These are based on figures which are extremely flaky. One of the great scandals, I think, of international public health is that the surveillance for malaria deaths is, particularly in Africa, is almost non-existent. So there's an enormous amount of extrapolation goes on. Careful extrapolation, and people have spent a lot of time trying to work this out, but you should never take these figures as being absolute figures. Nonetheless, there is such a consistent trend globally in the data from all countries that I don't think anybody doubts that malaria mortality has fallen substantially over the last 13 years. It may just not be by exactly these amounts. So this is all good news. I'm going to now go from the global, as it were, down to the very local. I'm going to present a picture of what's been happening where I've been working for a long time, for 25 years, with a whole range of colleagues, in Kilifi on the coast of Kenya. And the reason we went to Kilifi was there was a lot of malaria there. Now, the incidence here, again, it doesn't matter what the units are. What this actually is the number is an expression of incidence of severe cases, i.e. life-threatening cases of childhood malaria at Kilifi Hospital from 1990 onwards. And you can see that for many years, and those of you who visit Kilifi, especially in the malaria season, will know this, the hospital will just be groaning, literally overcrowded with children with severe malaria. A lot of malaria deaths, an absolutely overwhelming sort of disease during the rainy seasons. And this went on for many years. But you can also see something really I would have not believed possible, which is that it's almost disappeared. Now, it's not disappeared, but it's reduced by about 90% compared with what it was historically. So a really incredible drop in this one local setting. And you might say, well, this is a brilliant example of what happens when you really do put malaria control in place. But in fact, it's probably not. Widespread use of bed nets and ACTs came in here after the drop had been going for a long time. And in fact, you can see this much better if you look at some of the indices of declining transmission. So this is, the red line is the parasite rate in the population as a whole. And you can see that that had been dropping since the early 90s, steadily. And as you drop parasite rate, you have less exposure to malaria and you become less immune, or rather it takes you longer to become immune. And so if you look at the age of children in the hospital who don't have malaria, that's constant throughout. Look at the age of children presenting with severe malaria, it diverges, that rather annoying blip here, so you can't say whether it diverges here or here, but it certainly began to diverge in the early 90s. So that's very strong evidence that in fact this decline in malaria had been going on for a long time. And then at the end, the free bed nets, the ACTs, almost certainly had an extra effect. Now I have to be really careful at this point when I'm talking about this, to be clear that I'm not saying that it's bad to invest in bed nets and drugs. It absolutely is not bad. It's required everywhere. When it's done, it has a major effect. And it's certainly, if you remove these in Kilifi now, this would be pretty disastrous. But the point I'm making is that there's something very important going on behind this, which is that there's a helping hand pushing malaria down, which the application then of effective control tools is able to take advantage of. And it's important to recognise this because we don't know what that is. And as we don't know what it is, we don't know when it might reverse, and that would be a real problem. Now you might say, it's just a fluke, there's something weird about that little place on the coast of Kenya. But in fact, these are data from a demographic system right across on the other side in Niakhar in Senegal, in West Africa. Similar sorts of data looking at, in this case, it's actually malaria-specific mortality in a large surveillance system. And you can see that with the advent of chloroquine resistance, mortality began to rise. Then it has fallen steadily. And similarly, the fall had clearly begun considerably before the introduction of control tools. So this obviously isn't just a fluke from one little place in East Africa. What's happened to overall mortality, childhood mortality? Well, back to Kilifi now. So we're going to swap between East and West Africa for the next few slides. So this is childhood mortality, and this is very accurate childhood mortality because this is derived from a demographic surveillance system which we maintain in Kilifi, which is, I think, probably the largest in Africa, about 300,000 people. And again, if you'd have asked me, would this be possible 25 years ago, I would have said no. But childhood mortality is reduced by 75% over this period of time. Now, obviously, at this point, you will say, well, don't get drawn into the epidemiological fallacy. Sort of correlation is not causation. This is something which has happened at a time when malaria has been disappearing. Malaria causes an enormous number of deaths, but it would be a big stretch to say that malaria could cause that number of deaths. It can't have accounted for 75% of the total mortality. So you have to be very cautious about this. Switch back now to West Africa, now just south of the data I showed you before in the Gambia. It doesn't matter that you can't read these axes. The point is, this is an index from the early 2000s of malaria in 4 different places in the Gambia, and you can see it's the same picture. Malaria is coming down everywhere in the Gambia over the same period of time that we've been talking about in East Africa. And if you say, well, what's happened to total childhood mortality there? These data are derived from a very long-term demographic surveillance from the late 80s. And starting with very high levels. Typically, West African childhood mortality is higher than East African childhood mortality. So these are massive levels, 200, 250. It means sort of nearly a quarter of all children born are dead before they're 5. But you can see this is also reduced by 75%, the same figures in East Africa over the same period of time. Now, let me be clear again. This is overall mortality. It happened during the time when malaria was going down. I'm not at this stage, although I will in a minute, make the argument that this is because of the control of malaria. But at this stage, all one can say is it's happening. One thing that's really I always find fascinating about this is if you look at the biggest drop in the Gambian mortality, halved their childhood mortality. What intervention did that? A military coup and stopping foreign aid. So if you want to sort of really get on top of things, stop foreign aid and have a military coup. So I've been building up in the last few slides to the suggestion that maybe there's a relationship between the reduction in malaria and the reduction in childhood mortality. Now, at one level, there's bound to be, of course, because malaria accounts for quite a large proportion of childhood mortality. But it can't account for 75% of it. I mean, there's nowhere in the world where, even where malaria is the worst problem ever, it never accounts for more than 25% of the total deaths. So maybe lots of other things are getting better at the same time. Maybe this is a reflection of general health improvements, general social improvements. And again, I'm going to move now to arguing that that almost certainly is happening, but that's not the explanation of the relationship between malaria dropping and childhood mortality dropping. So first, I want to ask the question, is it even conceivable that there's something about malaria which could lead to more childhood deaths than you imagine? And some years ago, we tried to assemble the data, such as they were from all over Africa, on levels of all-cause childhood mortality against the level of malaria parasitization in the community, which is a rough index of how much malaria transmission there is. And what you can see from these data are that they're all over the place. So you could put a line through it, but it would be equally plausible to say that the relationship looks more like this, i.e. that there is more mortality as you have more parasitization. And in fact, there are a lot of data to back this up, historical data, where malaria has been controlled for short periods and then all-cause mortality has dropped. And the problem in interpreting these data is always the one of other things happening over the same period of time. You can never say, well, that's because you controlled malaria. And in fact, if it were the case, you'd have to say, well, what would the excess deaths be to? And you can have a good guess at that. If it were, so now we're kind of saying if it were true. If it were true that getting rid of malaria reduced childhood mortality more than you expect, what deaths would you avoid? You can have a good guess at this because to a first approximation, in most rural African communities, 90% of childhood deaths are associated with fever. And again, to a first approximation, if it isn't malaria, it must be invasive bacterial disease, because with the exception of measles, which is now largely controlled in Africa, there are no real other common causes of a young child dying with a febrile illness. Whatever the preceding conditions which may predispose to that, like malnutrition, the cause of death, to a first approximation, if it's not malaria, will be bacterial disease. So if there were a change in anything, it would be in bacterial disease. So this is what's happened to Bacteraemia, i.e. invasive bacterial disease, in Kilifi over the same period. So the black line is the malaria decline, which I've already been talking about. And the other lines, the blue line, is total invasive bacterial disease. It's halved. And you'll notice the proportional drop has been particularly marked for gram-negative bacteremia. So there has been, over this period of time when malaria has been dropping, a really marked reduction in invasive bacterial disease. So again, we're still at the stage of saying, yeah, but maybe that's because just health is getting better in general. I'm now going to make an argument that that's not the explanation. And the reason we don't think, in fact, I'm sure it's not the explanation, is because of sickle cell trait. Most of you will be familiar with the story that sickle cell trait protects people against malaria. It particularly protects against severe malaria and death. And that's the reason why you have high proportions, high gene frequencies or allele frequencies of something which in the homozygote is usually fatal in childhood. So sickle cell disease, when you have two of the genes, is normally fatal in childhood. And it's only risen to a high frequency in malarious areas of the world because when you have one gene, it extremely strongly protects you against dying from malaria. So there's a big selective advantage. Now this is a story that's well known and well worked out. Some years ago, for reasons I can't completely remember, we examined the effect of sickle cell trait, not in protecting against malaria, but in protecting against invasive bacterial disease. And we were not totally surprised, but we found that it had a very marked effect. And of course, the issue there is, so do we mean that sickle cell somehow, by some unknown mechanism, really protects you from developing invasive bacterial disease? Or is it possible that by preventing malaria, it prevents something which malaria predisposes you to, which seemed the more likely. But it was very hard to disentangle these. After every statistical correction one could think of, this apparently separate effect persisted. And we were thinking about how to deal with this, and we were thinking about how to deal with it, and we kept sort of saying we'll come round to it, and maybe we'll do some studies where there's no malaria, and the years went by. And then we realised, actually, of course, malaria, as the years were going by, was disappearing from Kilifi. So that actually presented without any, I won't say without any effort, it was a lot of effort, but if you like, it presented a natural Mendelian randomization experiment. And this is summarised here from a paper by Anthony Scott and colleagues in Kilifi. And I'll just talk you through this. So this is examining the effect. This is a whole series of, it's effectively what we did. We went back and because we had maintained surveillance at the hospital, we were able to obtain samples from every case of invasive bacterial disease admitted to the hospital over many years and genotype them. And then do a yearly case control study to look at the protective effect of having sickle cell trait against developing invasive bacterial disease. And the argument was that if this was mediated by malaria, then as malaria disappeared, the effect would disappear. And this is exactly what happened. So this is yearly case control studies. This is the line of unity, as it were, no effect in either direction. This is malaria declining over that period of time. And as you can see, rather gratifyingly, exactly what one had predicted happened, that the protective effect was lost completely. And so far as I know, and I keep sort of presenting this cautiously and hoping someone from the audience will sort of come up and say, no, I've thought of a brilliant alternative explanation. But so far as any of us can tell, that can only mean that malaria directly, I'm using directly in an odd sense, in some true sense causes invasive bacterial disease. i.e., it's not just that things get better, malaria goes down, bacterial disease goes down. There is a truly causal relationship in an important sense between being exposed to malaria and developing invasive bacterial disease. And in fact, if you sort of do the calculations, because bacterial disease, as I've said earlier, is more important than malaria, in fact, malaria might, in some important sense, cause up to half the cases of invasive bacterial disease. And this leads to the slightly surprising, to some, conclusion that if you really did effectively control malaria, you may prevent more deaths due to other things than you do due to malaria, even though you would prevent a lot of deaths due to malaria. So it's perhaps a slightly paradoxical idea that real good control of malaria would apparently lead to greater gains against other diseases than malaria. Now, this all sounds too good to be true. And in fact, I thought it probably was too good to be true. But there's a very striking example which suggests that this probably is the case. So this is Bioko. This is the island half of Equatorial Guinea. And this was a site of, if you like, I suppose what you call implementation research. It was decided to really get on top of malaria. Malaria is a major problem in Bioko. It caused a large proportion of childhood deaths. And from the early 2000s, a consortium of researchers and implementers decided they've really got to get on top of it. And they did this in a sort of very aggressive way in 2003, 2004. So summarised here are the childhood mortality rates for the 4 years preceding. Now these are, again, all-cause mortality. This isn't malaria, this is just childhood deaths. And summarised here are the childhood deaths after the initiative was started, the campaign was started. Now you can see something really very remarkable. Childhood mortality was reduced by 2/3, apparently by controlling malaria. But the most striking thing is it all happened in 1 year. It all happened in the year where malaria was aggressively controlled. And that really takes out the possibility that this is other secular things happening. Now, as I said, we're already sure that the relationship between malaria and bacteremia is not other secular things happening. That must be a causal event. But this is a very striking real-world example of if you aggressively get on top of malaria, childhood mortality just plummets. And I think this worries me so much that every time I see Imo, I always ask him sort of, was there a problem in the data? Have you discovered some awful problem in the data? But every time, they're all very confident about it, and many years have passed now. So I think this was the case, and it's very striking. So I've been largely talking about good news, that malaria is going down, and what's more, malaria doesn't only go down, you get a kind of dividend of other things disappearing, and this all sounds brilliant. There are a couple of things we need to be really aware of on the other side of the scale. And the first is Artemesinin resistance. I think many of you will have heard quite a lot about this, because there have been quite a lot of talks here about it. So artemisinin, I've said earlier, for those of you not familiar, that artemesinins are the key ingredient of artemisinin combination therapy. These are the drugs, as it were, which really work and which have now the standard treatment all over the world for malaria. And for various reasons, we thought it very unlikely that artemisinin resistance would emerge, but it has. It's emerged in the greater Mekong region. It was first observed around about 2006, but now I think it probably arose on in Cambodia and separately on the Thai-Myanmar border round about 2000, 2001. And it's getting worse. The colours on the map just show different levels of the way it's classified. But the key point is in these 6 countries of the greater Mekong, there is resistance emerging to the one drug which works really well and which is our standard drug all over the world. This is so concerning that in 2014 the WHO Malaria Policy Advisory Committee recommended that the only way to try and deal with this was to really push for elimination of malaria in the entire greater Mekong. This is a massive undertaking. This is an aim which has been endorsed by the leaders of all countries in the greater Mekong, and this is now the policy to drive for elimination of malaria, because it seems impossible otherwise to control the spread of artemisinin resistance. The other great worry is insecticide resistance. I've said that other than drugs, the thing we rely on are impregnated bed nets. So these are bed nets impregnated with insecticide. This is a global map of insecticide resistance. Grey or white, there's no resistance. Anything other than that, there's resistance. Well, actually, grey is no data, but this light one is no resistance. There aren't many like that. Basically, the darker it is, the worse it is. And these countries all have confirmed resistance to 3 or 4 classes of insecticides. This leaves practically nothing. Now, it's not quite as dire as it seems. You can maintain effectiveness, apparently, of impregnated bed nets with a certain degree of resistance. But as it gets worse and worse and worse, it's a reasonable expectation that control, due to both insecticide impregnated bed nets and spraying, will become more and more difficult. So we've got a spectre of resistance in 2 quite separate areas, as it were. Drug resistance and insecticide resistance. These are the 2 things which we rely on for the gains that we've got in malaria control. So I'm going to finish off by a cautionary tale of what may happen, I think what will happen, widely in Africa. So you've already seen these data. It's malaria, severe malaria coming into hospital in Kilifi Hospital. On the next figure, what the red line is the average data. So this is a year, as it were, January through to December, and this is the average data from the entire figure I've just shown you, as it were. So this is the average data throughout the year, with a big malaria season, sometimes a second malaria season. Here's 1999, which was a particularly bad year for malaria, where the actual data in green, there are many more cases than the average over the whole period of time. By 2009, as you've already seen, really gone away, almost gone away. Bit of malaria all through the year, but nothing like what was historically the picture. In 2011 and 12, it was looking the same, going along nicely, then suddenly, bang, in one malaria season came back up to the historical levels of severe disease. And that was, for reasons we don't fully understand, it may have been just a small increase in rainfall, maybe a bit of a fall off in impregnated bet coverage or whatever. But the key point is that with a small change in something, you can go bang, straight back to historical levels of transmission. And the difference here was that instead of seeing children with cerebral malaria aged 2 to 3, we're seeing children with multi-system disease, high death rate, age 7, 8, 9, 10, as you would predict, because the population has lost its immunity. This is the situation which our successful control is building up right across Africa. And so, if successful control ever slacks off a bit, this is the situation we will see in many countries in Africa. So where are we in 2015? Well, there's loads of good news. Malaria is falling in most of the world, in many, but not all, of Africa. There's real reason to believe that you get a disproportionately good fall or gain in childhood survival when you control malaria. there's been real renewed optimism about elimination, and I'm sure many of you have seen lots of this, particularly from the Gates Foundation. And there are new interventions emerging. Vaccines, there's likely to be the first malaria vaccine licensed this year. There are many other interesting vaccines, many of them in Oxford, sort of coming up behind, as it were. There are new drugs emerging, and there are new vector control approaches. So this is all good. But on the other hand, Artemesinin resistance, and you saw what happened when chloroquine resistance spread around the world. There's a doubling or trebling in childhood mortality, malaria mortality in Africa. Artemisinin resistance is now a fact. It's confined at the moment to one part of the world, but historically it won't stay confined to that part of the world. Insecticide resistance is emerging all over the world. Perhaps the most worrying is that there's flat and insufficient funding. I made a big point about this is wonderful that funding has gone up. Well, it is wonderful, but it's at about 2.5 to 3 billion a year, and it needs to be at 6 billion a year globally annually to actually even apply all the things that need applying right now. So it's only half of what it should be. And there are very large populations emerging, particularly in Africa now, whose immunity is falling as a result of a good thing, controlling malaria, but it won't be a good thing if that control is allowed to slack off at all. So some concluding thoughts. There's been a big debate about elimination and eradication, and in my view, there's no doubt that elimination and eradication must be the long-term goals. But it's very important that we don't become sort of deflected in a fit of enthusiasm which is not based on any evidence to imagine that we're going to achieve this in most places anytime soon. And in fact, elimination can't even be thought of until you've controlled malaria. For most of Africa, at least, the big issue is still to control malaria. Historically, many countries have come really close to elimination, followed by resurgence. And when resurgence comes, it's always terrible. India went down to a few hundred thousand cases, and went back up to a couple 100 million in a few years. Resurgence is always very rapid when it happens. There is a new global technical strategy for malaria, and there will be a new global action plan. The global technical strategy was adopted at the World Health Assembly a few weeks ago, and the global action plan will come out this year, which I think are going to be very important in driving through the focus on maintaining gains and sort of going forward. But the key point, as I've already mentioned, is that global funding has to be increased and sustained, and new tools need to be developed. New tools for sure, but without an increase in funding, it's impossible, I think, to see how you could ever get to the position which most enthusiasts seem to think will somehow suddenly happen. It's just not going to happen without a doubling of international funding, right? And that's just to apply what we can do now. That's not to apply new tools. So I hope I've given you a balanced view. I hope I've not depressed anybody. There are loads of good things happening, but there is a real potential for those good things coming to an end and things going backwards unless the focus is maintained internationally, and particularly funding is maintained internationally. So I hope that's given a reasonable balanced view of where I think we are with malaria at the moment. Thanks.